in EMG, but now we have chosen single fiber EMG as a topic, which I developed together with my colleague Ekstedt in the early 60s, and I wrote a thesis on that also. Some of the recordings here are made by our colleague from Brazil, who has been working with me for some short period. So here we shall first discuss a little about the principle of single fiber EMG and jitter analysis. When we talk about single fiber EMG, we can measure different things, fiber density and propagation velocity, but here today it's only jitter analysis, neuromuscular transmission, that we are going to talk about. The single fiber EMG is according to the following. Here is the concentric needle EMG, and this is the recording area, and it records 5 to 15 muscle fibers within about 2 millimeters radius. But for the single fiber, we have a very small recording surface here, and we also filter the signal so that low frequency components that are seen in the beginning at the end of the signal that are coming mainly from remote fibers is suppressed. So therefore we make an advantage of we favor the closest fibers, only 200 or 300 micron away from the electrode. So this is the technical principle, that we have very small recording surface. And then the medical principle is the following. Here we have an axon that divides into many muscle fibers, maybe 100, and each axon goes to one motor end plate for each muscle fiber in that motor unit. And the signal jumps over from the nerve to the muscle and travels in both directions from the end plate. And when we now are recording with our small needle electrode close to 2 of these fibers, we can record one signal that comes first and the other comes later, maybe because the conduction velocity here is a little slower and because of position of end plates. And then we get this type of recording from one fiber and from the other fiber. And that is so all the time when they are repeated, let's say with 10 hertz. But when we look at this very, very carefully, we see a slight variability in the time between the first and the second signal. And that is much better seen when we superimpose. Here we trigger, that means starts the sweep on the first signal, for example, and we see that there is a blurring here. And that is a problem that occurs in the neuromuscular junction. This is not absolute constant, but it varies a little from one discharge to the other. And that is of the order of 20, 30 microseconds. And that variability, which is happening in the synaptic gap, is called the jitter, and that we use mainly for myasthenia diagnosis. And here we have 3 recordings from the same patient from the extensor digitorum muscle. And the A here is that we trigger on the first signal and we see the variability on the second. You see a slight blurring. A few millimeters away, we have another motor unit, and here you see a larger jitter. And here we have even larger jitter, and also that individual signals are missing. And this is the so-called impulse blocking. And this gives a decrement on repetitive nerve stimulation, and this gives weakness. But this is the heart of the technique, that here we have a disturbed neuromuscular transmission, but all impulses are passing, and we can easily wait for 100 microseconds. Only we get the signal. So there is no weakness, no decrement here, and therefore single fiber is a pre-symptomatic or subclinical diagnosis of myasthenia, and therefore it is so sensitive. Only here do we have the repetitive stimulation decrement. Now I showed here that the eye could identify normal, slightly abnormal, and very abnormal. But we want actually to quantitate this by measuring the time between the first and the second, first and the second, first and the second, and get some kind of mean value of this variability. And that was originally done in the following way. We started a clock in the computer when the signal starts here, and when it passes through this window, this clock was stopped. So here it was stopped, and then next discharge maybe here, next time maybe here, next time here. So this was the variability. We get time intervals that we can calculate and express variability. Another newer method was that we, instead of measuring on the level amplitude, we measured from the peak, first peak to this peak, first peak to this peak, first peak to this peak. And this is called the peak analysis. And this gives exactly the same jitter value if we measure here or if we measure peak. It is true if the signals are separated, but if they are riding on each other, which is relatively common, then if we measure with the amplitude level, you can see that here we are measuring on the bottom part of the signal, and here we are measuring in the middle part of the signal. So we are not measuring on the same point, and that is bad. That will increase the variability, the jitter variation. So, but the peaks is the peak, the peak, the peak, the peak. So therefore the peak method is, I think, superior to the other technique. And in new machines, we mainly see this technology for the software. But we can leave that, and I will discuss that a little later on. And here we have the two types of display. Here is potential pair, two spikes, and here in blow up, and we set the level trigger here, the level trigger here, and then we get the variation. The first signal is here, and this is second, is it jumping up and down. So the jitter is seen on the y-axis. Another technique which we use for peak trigger is the following. We have the first signal here, the second here. Here I superimpose, and each peak is seen as a dot. Here is the triggering peaks, absolutely stable on the screen, and here is the variation, is the jittering peak here. So it is similar, but now the jitter is on the x-axis. In the previous, it was on the y-axis. So this is what we see, and this is what I'm mostly accustomed to. And then we measure jitter values and so on. Over the last 10 years, many hospitals in the world do not allow that we reuse medical material. It must be disposable material. And the single fiber electrodes are pretty expensive. So we were happy that we could use them 100 times or more. So that was not so expensive. But now, if we are not allowed, I mean, we cannot throw them away. And we have found that the smallest so-called facial needle, the small needle electrode, concentric needle electrode, can be used. It's a little different, but I will show here the principle. Here is the recording surface of monopolar, ordinary concentric, small concentric, and single fiber. And here is the area of the recording surface. And you see very, very small area here, pretty small here, and larger here. And we know that it is 200 micron between muscle fibers in a normal motor unit. So for the concentric normal, we may have 4 fibers in the just close vicinity of the electrode and a few more around. For the concentric facial, we have much fewer needle fibers, and here for the single fiber, it's only 1 fiber. So you see the concentric is somewhere in between the ordinary concentric and the single fiber. And here is a kind of practical comments. We use the concentric needle electrode. We hold the electrode like a pen when we insert the needle. We just put in carefully. We place it not perpendicularly to the skin, but maybe we have a slightly skew insertion. And we do not need to go deep inside the muscle, and that is true for ordinary EMG also. We can be pretty superficial. And we make very small movements in or out or rotation to get the good signals, and we listen to the sound. And for the biggest problem that we do is that we ask the patient with too much activity. We should ask the patient to relax, 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 so that we have only very few motor units active, and they should fire with relatively low but regular firing rate, something like that. And I do not start the software to collect data until I see a very good signal. I spend a few extra seconds to get good signals, and then we start the signal collection. We do not do much of editing afterwards. I nearly do no editing, but we go on the recording until we have good signals, and I want to have 100 discharges for each recording. And you know, with the frequency of 10 hertz, which is normal, then it takes 10 seconds to record a good signal. And if we don't get it good there, we go on for 10 seconds more. We do not go back with tape recorder and make editing afterwards. So 20 recordings from each muscle, and each recording has 100 discharges. And then you may ask, do you really need 100? Can we not do with fewer? Yes, we can go down to 50, but I should not like to have only 20 or something. But from 50 and up, it can be accepted. But be careful, slight contraction, then we get it. Okay. The technical part here is that we use filters of 1 kilohertz to 10 kilohertz. 1 kilohertz to get rid of low frequencies. For the ordinary EMG, in parentheses, we use 5 hertz to 10 kilohertz. For single fiber, we use 500 hertz, but for concentric electrode, 1 kilohertz. And now we shall only talk about the concentric jitter for the rest of this talk, because that is what we are going to use in future in all our laboratories. I hope someday we can get back to single fiber electrodes that are disposable, but so far it has not been possible. And now I will show a few typical examples of jitter recording so that you get the idea. Here is actually a nice, just single fiber recording, and here is the jittering part. And we trigger here, and you see that these are absolutely the same for each discharge. And I see that since these lines are parallel, and I will say that a few times this afternoon, that we look that these signals are parallel. Here is a riding signal, but they are parallel. So you see the peaks have been measured, these markers. So this is okay. Here we're triggering on the second, and if we trigger on that, it's stable on the screen, and we have the jittering part here and the jittering part here. And you see this is not parallel, and they are fluctuating very much, and this is not acceptable. This can be used. So we use a recording between 2 and 3 here. Here, they are not parallel at all if we look. So this must be a summation of more than one fiber. It is summation of 2, 3, 4 fibers here. So we skip this recording. Here is an ordinary single fiber, real single fiber electrode. And you see the variability in the shape here. And nothing changes, no notches or anything. And here is the jitter with concentric electrodes. Stable here, stable shape, stable shape. They are a little slower in this recording, but it looked nice. And they did not show notches or anything. Here we have another nice, acceptable concentric needle electrode recording. First we trigger here, and the second one, and you see how it varies back and forth, and no notches or anything. So that was the live recording of this. And now I will show you a few other recordings. This has a very small jitter during voluntary contraction. Trigger here, this is too low to be accepted, and this is nice in parallel. Here we trigger on the second. It doesn't matter if we trigger on the first or the second. Usually we trigger on the highest. So this is stable, and this is parallel, so this can be accepted, and the jitter is 21 microseconds. Here we trigger on the first, and then there's a variability in the second, third, fourth. And here is some spurious recordings. So we can measure between 1, 2, 1, 3, 1, 4. So we get three measurements here. And the jitter is similar to standard deviation in the time value. So the normal is something up to 30, 40 microseconds. I will show you, different for different muscles. So this is normal. And myasthenia has 60, 70, 100, 150 microseconds. Here we have the recording where we trigger on the second, and you see that this is not really a sharp signal. This must be another fiber that is contributing to this signal. So here is an inflection point. But this inflection point is way down, below 50% of the total amplitude. So, and we are measuring on the peak here. So this one we accept. If this variability had been on the top here, we should not have accepted. But this is fine, so we measure between this and this. Also, although we know that there are 2 fibers here. That was a little about the voluntary activation, and we can also activate with electrical stimulation. Here we have a monopolar needle that we put in and use as cathode, and we have very, very slight stimulation, maybe 5 milliamp, and a very short duration, 0.05 microsecond. We have a surface electrode as anode, And now we have when we stimulate with 5 hertz or 10 hertz, then we get a little twitching part in the muscle, and we insert the needle in the twitching part 2 centimeters downstream. And then we can get the signal. Here's stimulus artifact. Here is the variability. Here you see the jitter with the better blow up. And you say, how do you know that you're stimulating a nerve and not the muscle fiber? There are much more muscle fibers than nerves. Yes, first of all, nerves are more excitable, so it's more likely that we stimulate a nerve. But if we stimulate a muscle fiber directly, we have no motor end plate involved. So stimulus and response, there's no variability. And you see that here, no jitter. With no jitter, we mean less than 5 microseconds, because it can be some noise in the amplifier. Less than 5 is muscle fiber stimulation. More than 5 is neuromuscular junction, just one motor end plate. We can also stimulate with a surface recording. And here we have placed it over the facial branch to the frontalis muscle, stimulate 10 hertz, maybe 8 milliamp or so, and we get a slight twitch, and we insert the needle in the twitching part. Here is a major problem with the stimulation, and that's why I do not use that as my first method. I use voluntary, but sometimes we use electrical stimulation, namely the following. When we start to stimulate, then the nerve is just about to be stimulated, and it's very uncertain in the stimulation point, and therefore it is a jitter and even blocking. And then we increase the stimulus a little, and then you see it becomes more and more stable, and now this is normal jitter. The same signal has large jitter, increase the stimulus, and then it's okay. So if you do that every time, it's fine. Then sometimes when we increase the stimulus, all of a sudden a new axon is stimulated. And in the beginning, that axon shows a large jitter. And then we increase the stimulus a little more, and whoop, a new one comes in. So for each recording, we always have some axons that are nicely stimulated, some axons that are subliminally stimulated. So you cannot just measure jitter in all these different components. You have, like a hawk, have to concentrate on one of the spikes and check that that one is have a good stimulation. And particularly if you have a patient with myasthenia with a lot of jitter, then you have to increase the stimulus just very little. And if the jitter becomes normal, then it was not a problem. But if the jitter does not change in myasthenia, then it is a real true myasthenic problem. Here you have same thing. In this nerve axon, then we happen to stimulate from two, and then we increase the stimulus, a new one comes in, and then we stimulate a little more, a new one comes in. And this one has a large jitter and even blocking, and we say, oh, this is myasthenia. It's not true. We have to increase the stimulus just to check. And that is the little problem. Now, when we have the electrical stimulation, we measure the jitter between the start and the impulse, between the start and the impulse, not between two impulses. So the practical hints for electrical stimulation is that we stimulate with 5 or 10 hertz, insert the needle into the twitching part of the muscle, slight stimulus intensity to get few spikes, but we must have the intensity enough so that each spike is supraliminally stimulated, each spike that we are going to measure. And if the spike shows abnormal jitter, increase the stimulus intensity a little. And we measure between the stimulus and the spike. And that is how it is arranged in the machine. You don't need to think of that. And here is now some examples of electrical stimulation. We have stimulus to the left here, and here you see very nice recordings, and when we superimpose, fantastic. Here is 1, 2, 3, 4, 5 spikes, fibers, and then when we superimpose, we see parallel, but this one is obviously a summation. So we skip this one and we record between stimulus and this, and this, and this. So we get 3 values, 12.9, 19.9, 22. Here's another, it looks fine. This is sharp and nice, sharp and nice. And when you look at the first one here, you see that the first one there is not parallel, so these are not so good. And when we look at details here, this one should not be accepted either. But the others are very nice here. This was a funny one. It looks very good, but when we superimpose, they have a summation both here and here. So we have to skip that recording. Here's another recording. This is a patient with myasthenia, and you see this is a nice parallel rising phase. 2 signals we measure between the stimulus and this one, and the stimulus and this one, and get 2 values, and these are more than 35, so these are abnormal. And here's another patient with myasthenia, and you see that this second one is missing here, and you say, oh, and this has a very large jitter, and the jitter is 169, and then you say, oh, this must be myasthenia. Well, we don't know if we just see this picture. We must increase the stimulus from 8 to 8.5. We only need to increase it very, very little. And if this was due to technical factors, then the jitter should, this spike should come here, and everything should be stable. But if this is really myasthenia, then it is unchanged if we increase the stimulus a little. This one was unchanged, so this is true myasthenic problem. And here, when we superimpose, and you see a line through here because of the blocking. Here is another situation where we obviously do not have absolutely parallel lines, but you see something happens here. So here is another fiber, and here is another fiber. So there's a summation here. And we measure here, we get larger jitter than if we measure here. This is a situation that we don't like. So we skip this, and certainly usually it's more than this. So if the signal is not clean, exactly rising phase, we should skip it. Here's a situation, stimulation, and you see good, nice parallel rising, and here is a terrible situation. So this is not a large jitter, it's technical. And here it looks nice, even the jitter is small, but these are 2 or 3 fibers that summate. So we cannot just judge from the jitter value, but also we must check the shape of the signals. Some years ago, 2015, we made a multicenter study with Europe and America, Japan, and Brazil, and we collected some reference material for the concentric jitter. And we did the orbicularis oculi, frontalis, and the extensor digitorum. And we make normal values both for individual data. Just one recording should not be more than 45, should not be more than 38, and should not be more than 43. And the mean value of all 20 recordings have the values here. And we concentrated on the facial muscles here, and also we took the extensor digitorum. This is the most commonly used muscles for myasthenia. And the voluntary here and the stimulated here. I use stimulation in babies and in patients that have a movement disorder so that they cannot cooperate. Otherwise, I try to have voluntary activation. So then we shall just say a few words about the comparison between single fiber and concentric. Is the concentric technique as good as the single fiber? And I think we can say yes. There are many papers now from different authors, and they have compared, and the sensitivity of the two techniques is very similar. So we can trust the concentric jitter analysis, which is good to know. And here is an old comparison of sensitivity, the single fiber and the repetitive nerve stimulation and antibodies. And you saw single fiber sensitivity of 97% in ocular, 99% in generalized myasthenia. Rep stim is about 50% or 75%. And antibodies has also a relatively high sensitivity, but not 100%. In medicine, nothing is 100%, but you see it's very, very high sensitivity. If we do it correctly, if we are really meticulous about the quality of the signal. Now here's an important thing, that increased jitter and also abnormal decrementing response is not equal to myasthenia, but it says disturbed neuromuscular transmission. And that can be re-innervation, very typical, because there we have problems in the neuromuscular junction, electrolyte disturbances, and many other things. So increased jitter is specific for disturbed neuromuscular transmission. It is not specific for myasthenia. And here is a summary of what I have said about which signal should be accepted. They should be positive, negative going without notches or shoulders and being parallel. And the negative peak should be separated for good measurement. We can skip that. And we allow a slight variation in the signal, but in principle, they should be superimposable. And then, as I said before, the filters 1 kilohertz to 10 kilohertz. The sweep speed, we should have a high sweep speed so that we can see details of the signal. 0.5 millisecond per division. The gain, signals are small or large, it varies very much. So we increase the amplification so that the signal covers about 1 or 2 divisions, or 2 or 3 divisions. Around 2 divisions is good. And as I had shown on some of the slides, we usually superimpose also a 5 to 15 of the sweeps. We always look at them individually, and then we also look at superimposition. I should show a very tricky situation. Here, if we have a voluntary activation and it looks like this, you say, ah, here is a blocking, you say. But if we look carefully here, this signal is different from this one. So this is another motor unit that starts the sweep. Another motor unit that only has one fiber in that recording site. So this is not true. Here is normal jitter, and sometimes I get letters saying, how is it possible that we have normal jitter and blocking? And I say that is not a true blocking, it's a technical blocking. Because we have trigger here, and all signals that come above that level will fire the sweep, both the double one and the single one. So the solution is to lift up this trigger to the very peak here. Then I think I shall finish with the presentation here before we take questions about some of the questions that come very frequently. Can we measure fiber density with concentric EMG? Some of you that may have read something about single fiber know that fiber density is a way to look at very, very early reinnervation. It's a very good parameter, but we cannot measure that with concentric. With concentric, instead, we take the conventional parameters, duration, amplitude, and so on. So the answer is no. Which muscle do we use for myasthenia? Well, here we go for symptomatic muscles. I should say that if we have a patient with clinical problems in, for example, an arm muscle, and we make measurements there and find normal jitter, then it cannot be myasthenia. If the patient is weak or fatigable in the muscle, we must have not only jitter but also blocking. So normal jitter and weakness, that is not myasthenia at all. Usually for the diagnosis, I go to orbicularis oculi and frontalis. We start with one muscle, for example, frontalis. If that is abnormal, then I can stop here. If that is normal, I go to orbicularis oculi. And if that is also normal, I tell the patient to come back after 3 months. It is not useful to make muscle number 3 and number 4. It does not add much at all. 2 muscles is fine.
Great.
And Botox is a problem here, I should say, that sometimes we get unexpectedly increased jitter in a patient that has some symptoms, but really not myasthenic-like symptoms. Then I ask the patient, did you take Botox? And then they say, yes, but that was long ago. It was a month ago. That can be the whole explanation. Botox remains for a long time, much longer than we think. Here I written 3 to 6 months. Some people say even longer. So if you have Botox in a patient, then it's difficult to trust the jitter value. And then if the jitter is normally in orbicularis oculi and the patient has a ptosis there, then ptosis means weakness. And if that is due to myasthenia, the jitter must be increased with impulse blocking, as I said. If jitter is normal, we must say that it is likely to be another diagnosis. So this is my second last slide. Here it says that we have some links. I have my own homepage, and there we have some extra information and some lectures and so on, erikstalberg.com. And then we have a special homepage for single fiber, singlefiber.info. There we have 56 videos that you can watch and look at different details. And we have information about courses and other things. So you're welcome to look at that. So I think we have 45 minutes, and that was what we promised. So I stop here and thank you for listening. And if someone has some question, I'm ready to read them, and maybe I can answer. And the other thing is that if we do not cover all the questions now, or you have other things, you can write to me on an ordinary mail. Yeah.
Okay, I'm really appreciate your valuable time for this amazing talk about tips and tricks of something of the concentric needle EMG. And I'm very glad, especially in Egypt and some Arab countries, to use the concentric needle in single fiber EMG, which is, I mean, a gift for us, for its very cheap and can use. So I want to ask one question. In severely acute myasthenic patient, we cannot judging with the repetitive nerve stimulation, we cannot get the diagnosis. So it must to use single fiber EMG to get a hit on this diagnosis. Yeah.
Yeah. Yes.
So we can use the concentric needle EMG in every muscle, or restricted for the cranial muscle and very small for using a facial concentric needle only.
I should try to make my answers very short. It is easiest to make measurements in the facial muscles. The easiest to get good recording, but the concentric jitter can be measured in all muscles where we do EMG. Neck muscles or arm muscles, leg muscles, no problem.
So I have questions. It's very first one. Can the area of the trigger wave differentiate whether it is a single fiber potential or summated one?
No, I don't think so, because the area of the signal is not a good, trustful, robust parameter at all. The best is to look at the shape, and it should be a clean positive, negative going with constant shape from discharge to discharge, but a variable latency.
The second one, what are the practical criteria to choose a pair for analysis in volitional single fiber EMG with concentric needle?
What are the practical criteria for choose?
A pair for analysis in volitional single fiber EMG with concentric.
Yeah. You mean which type of method we should use?
Yeah.
Is that? Yeah. I think it is less critical with voluntary, less artifacts. It's more problem with electrical stimulation to get good recording. But some laboratory use stimulated as first choice, but many laboratories use the voluntary as first choice. If we have good technique, they are equally sensitive.
Yeah. Can single fiber EMG differentiate between congenital ptosis and myasthenic ptosis?
Not really. You said congenital myasthenia, and what the other was? What was the other question?
How can differentiate with single fiber EMG between congenital ptosis and myasthenic ptosis?
No, I should say both have a jitter, abnormal jitter, and there is nothing special to it.
Okay.
Theoretically, we can differentiate between myasthenia and Lambert-Eaton myasthenia, but that is easier with repetitive stimulation.
Okay, another one. In ocular myasthenia, what is the best muscle to be selected to examine surface fiber EMG?
Frontalis and orbicularis are equally good and equally simple. So one of them. Start with one of them, and I like frontalis very much as the first muscle, but orbicularis oculi is also fine.
Okay. Can we use concentric fiber, concentric needle for jittering in such case as Miller-Fisher and congenital myasthenia?
Congenital myasthenia, absolutely, and it is a Dr. Dr. Pitt in Queen Square in London, Children's Hospital in London. He has a big clinic where it has nearly 100 patients with congenital myasthenia, babies. And he uses electrical stimulation in babies, and it works very well without sedation.
Great, thanks. Any question? I think we have just 2 minutes. Okay, do the normative change if we do stimulated surface fiber EMG under anesthesia in infant and children?
You mean the normal values? Is it?
Hisham, if you listen, can you? It's in the normative change.
Yeah.
Do stimulated surface fiber under anesthesia. The same parameters or some?
Yes. It's the same parameters, and the normal values for babies may be slightly different, but at least down to 5 years, it is the same as what we have reported.
How can you enumerate the number of beers to reach 100? Is it manual?
We in the machine with software, it is always a counter, so you can easily see that now you have 100, no problems.
Okay, I appreciate your time. I'm so honored to be with us. Thanks, Professor Erik. Hoping another talk. I know tomorrow you have another talk.
Yes, yes. Well, thank you very much. It was a great honor. I have really liked this very, very much. Thank you for listening. Good night.